Okay. All right. Yeah, go ahead and talk through this one as a team. And you don't need to send in anything on your clickers. Just talk about it, and then you can hold up your fingers or finger in your team. Go ahead.
Question.
Yeah.
So what is drawing the sperm to the exact egg? He's like, what tells him like keep swimming, keep swimming.
Yeah, I mean that's just what they're programmed to do for the most part, but there are some chemicals that the egg releases as well that can kind of like attract the sperm, but it doesn't attract all of them for some reason. So
It was in one side of it. Because I was wondering, I was like, maybe it's like chemicals are like drawing it towards it.
yeah.
But then like when all the sperm know to follow that.
Yeah, totally. There are some chemicals released by the egg that can attract them. They're kind of like these like pheromone type things, but it doesn't attract all of them. So it's probably just a matter of like how much space there is and which way they're going. And,
Okay.
but yeah,
Okay.
so, yeah,
Thank you.
totally. Yeah. Yeah, just hold up your finger. Yeah, no clickers needed. Yeah, go ahead. Hold up a finger or two. Whoever is gonna do that on your team, choose somebody to do the voting. Hold it up so we can see here. Every team's got a vote. What do you got? Yeah. Yeah, so it looks like everybody's saying pretty much the same thing, which is C and D. So a failure to close the passageway between the abdomen and the scrotum, and then a condition in which the intestines can end up in the scrotum, right? So during development, the testes kind of drop from the abdomen into the scrotum, and that passageway is supposed to close up for the most part. It doesn't close up completely because there's still structures you need to get through there, but it closes up for the most part. And when it doesn't close up all the way, that leaves that open. And then, yeah, the literally intestines can kind of move through that hole into the scrotum, which can then pinch off the intestines and lead to some pretty serious consequences. So yeah, that is an inguinal hernia, which is different than a regular abdominal hernia, right? An abdominal hernia kind of pushes through the abdominal wall and sticks out kind of higher up. Inguinal hernia goes into the scrotum. So questions on that? Yeah, Sid? You can't see it. It can be felt in the scrotum, but it doesn't like pop out as much. If enough of the intestines go down into the scrotum, then it definitely like enlarges the scrotum a lot, but it doesn't like pop out like a abdominal hernia does. Yeah. Yeah, Caleb? Yeah. So this one is more of the abdominal hernia, which is with when the abdominal wall stretches out. Um, and then E is can push out of the abdominal wall. This is also same thing. This is also through an abdominal hernia as well. Yeah. Mhm. Okay, good. All right, next one. So just a bit of labeling of these structures here. So go ahead and yeah, just walk through this, and you can go ahead and hold up the answer to this one here in your team. Okay, go ahead. All right, go ahead and hold up your answers to the ones that I have starred there. Which structure is cut during a vasectomy? Yeah. Okay. Yeah, so everybody's saying B there. And yeah, so the structure in A is a spermatocord. That kind of contains everything that is going either to the testes or away from the testes, right? So blood vessels, nerves, the sperm, the tube that's going to carry the sperm and the semen. All right, B is the vas deferens. Okay, and so it's called a vasectomy, right? Anything an ectomy means we're removing something from the body, right? A meniscectomy, right, means taking part of your meniscus out, right? So vasectomy means they're just taking part of this little tube, taking it out, and they usually cauterize both sides of it. And so there's just no connection there between the urethra and the tubular part of the testes anymore. So yeah, so that's that one. Okay. And then C would be the seminiferous tubule. And this is where sperm production starts, right? This is the kind of the beginning part of it. It's pretty much the deepest part of the tubular system, right? So in here, and this is where all the mitotically dividing cells are. Um, and then all the early sperm are there as well. And then D is just this kind of membranous structure that kind of holds it all into place and protects all that tubular part. And the tunica albuginea. And we'll see something similar in ovaries of females as well. They look very similar to the tunica albuginea as well. And so the initial site of sperm production is that seminiferous tubule, what was that? That was C there, yeah. Okay. All right. Questions on those at all? Okay. All right. And then, yeah, let's go ahead and do one more labeling thing here, which is labeling of more of the external genitalia. So go ahead and walk through that sentence there. Make sure you're kind of just labeling all of it, but then fill in the answers on the top there. Go ahead. You guys can hold that first one up with your finger when you're done. But go ahead and label all of these structures. You just hold up that first one. Okay.
So does the body just know to stop producing sperm when someone gets a vasectomy? Because I like when the like test explode with sperm, that's because there's
Yeah.
nowhere to go.
Yeah, I mean, so yeah, I think eventually they do just stop. But I think in the beginning there is like a lot of production, but I think the production is somewhat regulated by the amount of sperm that's in there too. So like if they're not leaving, then that probably kind of provides some negative feedback to
Yeah,
the production. But then I think eventually they do just kind of stop producing once they're never leaving anymore.
Okay. So it's just like negative feedback. It's like
Yeah.
there's already enough in here. We don't need to-
Exactly. Yeah, for the most part. Yep. Because it can be reversible about 50% of the time. So that would mean that they haven't stopped fully producing yet, you know. But it's only about 50-50 chance that it actually will work again.
Yeah.
So yeah.
Okay,
Yeah.
thank you.
Mhm.
And then, so this was.
So, we need to send them the story down, the possible. Yeah, what's that in? You're in. Send me Jack. Start, you know.
All right, go ahead and hold up your answer just to that first fill in there as a team. Yeah. Yeah, so most of you are saying A there. So A is called the seminal vesicle or seminal gland that produces the majority of the volume of semen. And then the first place where we have shared, there's a shared tubular system between the reproductive and urinary systems. What'd you guys put for that one? What letter? Just yell it out. F, yeah, yeah. And so that is hard for me to follow that. Yeah, right here, right? Because we can see that kind of branching, right? So the bladder right here, and then from the seminal vesicle and the spermatocord here, right? But then right there, it's shared again, right? So then a little bit more addition to it there. We'll talk about what that one is in a second. But yeah, so there's some shared system where we'll see in the female, there's no part of the tubular system that's shared like that in females. So, okay. And then B, the ejaculatory duct. So that's all lined with smooth muscle for ejaculation to move everything through. C is the prostate, right? The prostate gland tends to continue growing throughout life, and it's pretty common for males to have what's called benign prostatic hyperplasia, which is just like the prostate just keeps getting too big, and you can see why it would affect urination, right? Because the urethra goes directly through it, right? So if that thing's getting too big, it's just going to start smashing down on the urethra and make it hard for urine to pass through. Yeah.
Like, it secretes food, but we don't know why, and it causes so many problems.
Yeah.
Why is it not?
It's because the risks of the surgery are significant, because because it's a pretty delicate area. There's lots of nerves going in this area, and so it's somewhat common to have some like level of incontinence after prostate removal, as well as kind of lose the ability to have an ejaculation and things and erection and things like that. So a lot of the nerves that pass through there are just it's just tricky to not hit something. So the prostate's definitely removed frequently, but it's just like those risks are there, so they don't do it unless it really needs to be removed. But yeah, it's a good question. Yeah. Okay, and then moving right along there. So D is the bulbourethral gland. We'll see some glands with similar names in the female as well. So that just adds some additional uh, content to the semen as well. More of the alkaline fluid, but that's kind of pre-ejaculation. And then, vas deferens, we already saw. And then finally, the prostatic urethra is that first part of the urethra that's kind of shared between the two systems. And just a couple other things I forgot to mention about the vasectomy. Vasectomy, again, would be kind of just like cutting a bit of this tube out and removing it. And it is about, if it's done properly, it's 100% 100% effective birth control, but it's only about 50% reversible. So sometimes if the male decides that he actually wants to have babies more, have kids after the surgery, then they can kind of go back and try to put the tube together, but only about half the time does that work. So part of that has to do with the testes will just eventually stop producing sperm if none of them are leaving. And part of it is just kind of getting that tube to actually go back together in a way that everything can pass through properly. So, yeah. Questions on any of that? Okay. All right. Okay. So go ahead and talk through this one with your team. Hold up your answers when you're ready. All right, hold up all your answers that are correct here as a team. You can use a couple hands, couple people if you need to. Okay, all the teams vote. Let's see. All right. Okay. Yeah, so most people are saying A. Okay, so lack of nitric oxide release in the blood vessels in the penis. That's true. Okay, nitric oxide is an important vasodilatory chemical. We'll talk a little bit more about it when we talk about the vascular system because it's produced by all the cells, the endothelial cells, the cells that line our blood vessels. But that's what leads to vasodilation. And then a lot of you were saying E as well. I saw that, but also D is one. So D, damage to the endothelial cells in the blood vessels of the penis. That's kind of the same idea as lack of nitric oxide release. That means those endothelial cells aren't functioning properly. They're damaged in some way. And that's known as endothelial dysfunction. And it's the same thing that causes cardiovascular disease. So cardiovascular disease, when people have heart attacks and strokes, the first step in the progression of that is endothelial dysfunction. So it's linked to erectile dysfunction as well. And then this is one that just kind of came on the scene more in the past decade and a half with the rise of the internet and the availability of pornography. But when males get so used to having kind of extreme stimuli that aren't really normal sexual encounters, then when they have a real sexual encounter, it doesn't work the same, right? Because their brains are kind of rewired in a different way. And so it's kind of this rising diagnosis that's occurring in younger males, not over the age of 40, with erectile dysfunction. So, yeah. Questions on any of that? Okay. All right, well, let's keep going here. Go ahead and chat about this one here and hold it up when you're ready. All right, if you're ready, go ahead and hold your answers up here. Okay. Yeah, so most people are saying B and E. Okay, so B is the Sertoli cells are stimulated by FSH. The Leydig cells are stimulated by LH. That one's kind of helpful because it's an L with both of them, right? And as I mentioned before, neither of these hormones are named for what they do in the male, right? So males don't have a follicle around their eggs. They don't have eggs, right? But the follicle is what surrounds the egg in the gamete, the female sex cell. And then so that's follicle stimulating hormone, right? And then LH we'll talk about as well, but that's a luteinizing hormone, which is related to ovulation as well. But they both have important functions in males too. They're just not named for what they do in males. And then most of you said E. So then once they're stimulated, what do the Sertoli cells do? They release something called inhibin, as well as those Leydig cells release something called testosterone, right? So they get stimulated by a certain hormone, and then they have Sertoli cells have more actions as well, but one of those actions is inhibin release. So, okay. Questions on that? Okay. So this next thing is just to kind of for you to practice drawing out the male sex hormone loop. And so this is what I recommend for all of the endocrine stuff when you have when you're studying for it, is to just start from the top. What's the stimulus? Okay, what's the first gland that needs to release something? What does it release? Where does that one go to? What gland? What does it release? And then what are the actions there? And then where's the negative feedback, right? So just try to go ahead and just walk through that with your team, give each other some feedback on this, and then we'll come back together and just check in on that.
Yeah, I'm not gonna. Inhibin only blocks the pituitary.
Is that what it shows on there? Yeah, I don't know if that's accurate on of that image. I think it blocks both, but that might be the way it shows it on there. Yeah, that would be my guess, but I think that image is a little bit off, but you might be right.
Are these not to see?
Yeah, yes,
Okay.
your chance to practice it.
Oh.
Yeah, that's kind of like the answer. Yeah,
Right.
you can for sure. Yeah.
Well, I mean, this is responsive. So if you've been, it's not in.
All right, let's go ahead and walk through this by looking at the next slide. This has all of it here, right? So what's our first gland involved in this? Hypothalamus, right? So hypothalamus is going to be there. It's going to release some hormone. You don't need to know the name of, but it's GnRH, right? And then that is going to go to the anterior pituitary. And that anterior pituitary is going to release two hormones, right? One of those is FSH, okay? So FSH is going to go to those Sertoli cells like we were just talking about, right? And then it's going to cause the release of a bunch of things mostly involved in sperm cell development, right? As well as maintaining this blood testes barrier here, okay? And so this is all like one cell right here, right? So it's a big cell that kind of houses all these developing sperm cells, okay? So that's what the FSH is doing. And then and then it's also, yeah, and then the next one from the pituitary is LH, right? So LH is going to go to those Leydig cells, which are smaller cells kind of on the outside there. But those ones are going to then release testosterone, right? So the Leydig cells release testosterone. And from there, we get a bunch of effects here, okay? Part of that is sperm development. Part of that is growth, okay? And kind of write those in here. So, oops, so sperm development would be one of the broad actions, right? Two would be growth of tissue, right? So testosterone is an anabolic hormone, right? So it causes muscle growth, causes bone growth, causes all growth. And then the third one would be sex characteristics, right? So male sex characteristics. Thickening of the bones in certain places like cheeks and the jaw and things like that. Facial hair, pubic hair, things like that are all related to testosterone release. And so we're seeing, oops, I covered them all back up. There we go. And then testosterone there, right? Testosterone is gonna, sorry, yeah. Say that one more time. You're just wondering what I wrote. Yeah, so this one, testosterone has three broad actions. What are they? That's the one I was answering there, yeah. Yeah. Testosterone is released. That was just looking for like a number if I was going to do this on the clickers, which would have been 5, right? Yeah, so that'd be number 5 there. Yeah, and then we got the testosterone giving negative feedback, right? So some of the negative feedback comes from testosterone to both the pituitary and the hypothalamus. And then inhibin, also being released by those Sertoli cells, also provides negative feedback. This is showing just the pituitary, but it's probably also the hypothalamus as well. Okay. Questions on that? Okay, we can just talk through this last one real quick. And so the problem here with exogenous testosterone use is it's the negative feedback, right? So if we're putting a bunch of testosterone in the body, we're getting negative feedback up here, which means we don't release FSH and LH. That's fine for the testosterone release part because we've already got plenty, but it's not fine for everything else that FSH does, right? Which is sperm development, maintaining the blood testis barrier, all of those things, right? So we're not getting FSH release because there's so much testosterone release. And then that blocks all of the kind of other effects that aren't directly testosterone related of the FSH and LH. So yeah, so the answer to that one, the most important one there would be this one. All right, guys. Have a great rest of your day. We'll see you on Wednesday.